So thank you, Dr. Molina, for that very generous introduction. I would also like to thank the organizers for giving me the opportunity to share this talk to our society. So the outline of my lecture is very simple. I will start with a brief introduction of cIMPACT Now and give a summary of the 7 updates that were published throughout the years and show its impact on the upcoming 5th edition of the WHO classification of tumors, which is expected to be published this year. So the WHO classification of tumors of the CNS released last 2016 brought about a major shift in how neuropathologists analyze and diagnose brain tumors by combining both morphology and molecular data in the definition. For a variety of reasons, formal WHO updates can only occur every decade or so. However, due to advances in molecular technology, there has been an acceleration of our understanding of certain tumors that may progress faster than the WHO updates. So, in response to this, cIMPACT Now was created in 2016, sponsored by the International Society of Neuropathologists, and consists of neuropathologists from different countries, divided into working groups, and plus a clinical advisory panel whose members include oncologists and surgeons, among others. So cIMPACT Now stands for Consortium to Inform Molecular and Practical Approaches to CNS Tumor Taxonomy, not officially WHO. Although major impact in tumor classification is from the WHO Blue Book, this initiative aims to facilitate consensus review of novel diagnostic relevant data and how such information can be integrated in future CNS tumor classification. Therefore, the goal of this process is to see impact in selected tumor types and in time the WHO. The first update was published last 2018 by Working Committee 3 and it tackles the use of the terms NOS and NEC and clarifies the distinction between both. Not otherwise specified are presently seen in certain tumor types in the WHO. By definition, the NOS designation indicates that there is insufficient information to assign a more specific code or WHO diagnosis, so it doesn't actually refer to a specific entity and is used during cases when classification into a more defined group is not possible. The designation may be applied to the following situations. So first, when testing was never performed. For instance, when additional molecular markers are necessary for a more definitive diagnosis, or when the biopsy is too small and not enough material is available for further testing, or if the patient will be given palliative care regardless of the specific diagnosis. Second, when testing was performed but the assay didn't work. So, for example, when the tissue is not properly preserved or the test result came out as equivocal. Lastly, when testing was performed but did not demonstrate findings that allowed for a specific WHO diagnosis. So, for example, when a diffuse glioma that is negative for the mutant protein tested with IDH1 R132 IHC and further sequencing was no longer performed. On the other hand, for the NEC or not elsewhere classified criteria, the necessary assays were performed and results are available, but NEC diagnoses do not allow for a specific WHO diagnosis. These are similar to descriptive diagnoses when tumors do not conform to a specific entity. So this is usually applicable to entities that have available molecular information that were not described yet in the WHO. So this table just shows an example of how NOS and NEC diagnosis can be applied in adult grade 2 diffuse gliomas. So when there's no genetic information available, the NOS designation should be used in the morphologic diagnosis. So if, for example, there's a lesion that is morphologically an oligodendroglioma, but genetic testing showed IDH mutation but no co-deletion of 1p19q, then the entity can be designated as diffuse glioma, IDH mutant, not elsewhere classified. In summary, after the release of the first cIMPACT Now update, the NOS designation provides an alert that a full molecular impact has not yet undertaken or was not successful. Therefore, further testing must be performed. So the NEC designation provides an alert to treating neuro-oncologists that the tumor does not conform to standard WHO diagnosis despite adequate workup. So since there is just the recommendation, the attachment of the exact not elsewhere classified phrase may not be necessary. The more important way of diagnosing is using the layered reporting, which displays the histologic and molecular data together and should be used at the same time. So the second update was published last 2018 by Working Committee 3 as well, and it clarifies the use of the term diffuse midline glioma H3K27M mutant and provides a diagnosis pathway for IDH mutant diffuse astrocytoma or anaplastic astrocytoma. This image shows the page of diffuse midline glioma H3K27M mutant in the 2016 WHO, and it is defined as an infiltrative midline high-grade glioma with predominantly astrocytic differentiation and K27M mutation in either of the following. So the diagnosis connotes a poor prognosis and a 2-year survival rate of less than 10%. So a surrogate IHC marker is commercially available, which is useful to identify the mutation, your H3K27 stain. With more use, additional tumors with this mutation will likely be reported. So a few important points should be taken into consideration with interpretation. It needs to show nuclear positivity, and cytoplasmic staining in macrophages and or microglia should be considered as negative. So furthermore, interpretation should be in conjunction with loss of trimethylated H3K27 staining. The definition of an entity using a specific molecular characteristic naturally draws attention to its diagnostic utility. So looking further at the next section of the WHO Blue Book description, it was noted that within the brain, these mutations occur exclusively in diffuse midline gliomas. However, as more lesions are being subjected to molecular testing, this section is now known to be incorrect. These mutations are not exclusive to diffuse midline gliomas and cannot be used in and of themselves to define a diffuse midline glioma with H3K27M mutation. Here are some of the published articles that identified H3K27M mutations in a few low-grade gliomas. This slide in particular shows a study that looks at several circumscribed and diffuse glioma cases and divided them according to H3K27M mutation status. So naturally, the circumscribed H3 wild-type lesions have the best prognosis, followed by the circumscribed H3K27M mutant cases, then the diffuse H3 wild-type lesions, and lastly, the diffuse H3K27M mutant cases. In summary, for the first issue in Update 2, the diffuse midline glioma, H3K27M mutant diagnosis is reserved only for tumors that are diffuse, midline, gliomas with H3K27M mutation. For a tumor that is H3K27M mutant but not a diffuse midline glioma, the mutation should be reported and an NEC designation should be considered. So for the second issue, when we look at the algorithm in the WHO Blue Book, it nicely shows the histologic and molecular distinction between the common diffuse gliomas. So the term oligoastrocytoma is already an obsolete term, and classification of a tumor between astrocytoma and oligodendrogliomas have been made possible with the availability of testing for IDH mutation status and 1p19q co-deletion. By definition, a diffuse glioma that is histologically astrocytic but has 1p19q co-deletion and IDH mutation necessitates a diagnosis of oligodendroglioma. As a result, confusion has arisen as to whether all diffuse gliomas need to be analyzed for 1p19q status to meet the diagnostic criteria. So if 1p19q status analysis is required for all diffuse gliomas, this will have a drastic effect in the turnaround time for definitive diagnosis. So, in response to this confusion, the update states that in the setting of a diffuse astrocytic appearing WHO grade 2 or 3 tumor that has IDH mutation and loss of ATRX nuclear expression and or strong diffuse p53 immunopositivity, a diagnosis of diffuse astrocytoma or anaplastic astrocytoma IDH mutant can be rendered in the absence of 1p19q testing. Several caveats with regard to assessment of ATRX and P53 stains were mentioned in the article. So for ATRX, it can be patchy with regions that lack overall staining. So you must see positive internal control, which are your background endothelial, glial, or hematopoietic cells. So the lesional cells are actually negative. For p53 staining, it can be variable in both intensity and number of nuclei staining. Extensive and strong nuclear positivity can be confidently interpreted as harboring a TP53 mutation, such as the one shown in the image. Absence of nuclear p53 staining does not exclude the possibility of a TP53 mutation. So either diffuse positivity or totally negative are suggestive of a TP53 mutation. P53 staining pattern that is suggestive of a wild type gene has rare scattered nuclear positivity, usually less than 10%. So, in summary, for the second issue in Update 2, a diagnosis of IDH mutant, diffuse, or anaplastic astrocytoma may be rendered using a purely immunohistological workup, leading to decrease in confusion and as well as diagnostic turnaround time. So the third update was published last 2018 as well by Working Committee 1, and it recommends a diagnostic criteria for diffuse astrocytic glioma, IDH wild type with molecular features of GBM. Once again, this algorithm shows the classification of diffuse glioma based on histologic and genetic features, and the most important genetic feature would be the IDH mutation status of the lesion. Numerous publications have already established the correlation of IDH mutant tumors as distinct categories with better prognosis. However, IDH wild-type grade 2 and grade 3 gliomas remain under a provisional entity. So in relation to this issue, there are several studies similar to this one that show a subset of IDH wild-type gliomas with an aggressive clinical course, regardless of having histology equivalent to grade 2 or grade 3 lesions. As such, the lack of IDH mutation is insufficient to label a glioma as a grade 4 tumor, but there are specific molecular markers that may be predictive of a worse clinical outcome. After evaluation of literature, the consensus focused on three molecular features, which are EGFR amplification in exons 1 to 10, combined whole arm chromosome 7 gain and whole arm chromosome 10 loss, and third promoter mutation. For EGFR amplification, it shows excellent specificity for gliomas with aggressive behavior. EGFR amplification refers to focal high-level copy number gains of the EGFR gene, and it should not be measured using your EGFR IHC. Combined whole chromosome 7 gain and whole chromosome 10 loss shows excellent specificity as well, with the rare exception of pleomorphic xanthostrocytomas. So the consensus restricted their recommendations primarily to the most common chromosomal imbalance only, and did not include partial chromosomal gains or losses. For third promoter mutations, they occur most commonly in IDH wild-type gliomas with your gain of chromosome 7 and loss of chromosome 10 or EGFR amplification. So other types of IDH wild-type glial neoplasms without WHO grade 4 histology or aggressive behavior have also been reported to occasionally harbor third promoter mutations, specifically such as your oligodendroglioma. So it is therefore critical to establish that a CNS neoplasm is diffusely infiltrative, has astrocytic lineage, and does not contain IDH mutations before applying third promoter mutation as a marker of WHO grade 4 behavior of IDH wild-type gliomas. This paper shows a distribution of EGFR amplification, combined gain of chromosome 7 with loss of chromosome 10, and third promoter mutation in brain tumors and their potential for reclassification of grade 2 and 3 astrocytomas to glioblastomas. The mutation with the lowest specificity is third promoter mutation, as expected, and the highest would be EGFR amplification. If two or more mutations are noted together, then the specificity increases to above 99%. Other proposed parameters worth mentioning are as follows, but these are not included in the recommended criteria as of now. So, based on the consensus, despite controversies, the minimum molecular criteria for grade 2 or grade 3 diffuse gliomas with clinical course of an IDH wild type glioblastoma are the following: EGFR amplification, or combined whole chromosome 7 gain and whole chromosome 10 loss, or third promoter mutation, or any combination. In summary, for the third cIMPACT Now update, it was emphasized that the IDH wild type category is a mixed collection of tumors, and a particular subset of grade 2 and grade 3 may be compatible with glioblastoma WHO grade 4 according to the molecular criteria that were previously presented. So this reclassification scheme would alert the clinical neuro-oncology team to important prognostic and potentially therapeutic information. So with this recommendation, the use of the integrated layer diagnosis is once again suggested. The fourth update was published on March of 2019 by Working Committee 2, and it proposed the use of classifying diffuse gliomas characterized by specific mutations. The division of IDH mutant and IDH wild-type lesions has been revolutionary in neuropathology, but this revolution brought out some questions and confusions. Some equated IDH wild-type with lesions that have a more aggressive clinical behavior, but in other less common gliomas, especially in younger age group, this is not the case. They actually lack IDH mutation and also lack the prototypic genetic alteration of IDH wild-type glioblastomas. Therefore, signatures predictive of aggressive clinical behavior will not apply to most pediatric diffuse gliomas. So this publication from the St. Jude Group describes the alterations of primary cerebral low-grade neuroepithelial tumors using a combination of several molecular methods, which include whole genome, exome, and transcriptome sequencing, Sanger sequencing, FISH, and DNA methylation profiling, which showed the following results. The dominant alterations noted in the sample population were FGFR123, MIB and MIB-L1, and or BRAF mutations, which collectively occurred in 78% of the series. Another study showed similar findings from low-grade glial and glioneuronal tumors. So what does this imply? From published literature, it was noted that these IDH wild-type gliomas that are uncommon are mainly seen in children, epilepsy-associated, and are low-grade. On the basis of data, it was recommended that the following classifications would provide valuable diagnostic and prognostic information for some entities, suggest targeted therapies, and separate these from other more clinically aggressive IDH wild-type diffuse gliomas. So before concluding, again some caveats for IDH wild-type pediatric gliomas. One should keep in mind that combined morphologic and genetic assessment will not always facilitate a definitive diagnosis, for example, in cases with sample size issues. So, shared morphologic features may be present among different tumors with the same genetic alterations. There is overlap between the histologic features and genetic alterations of diffuse glioma, therefore, reporting using the integrated diagnosis format is again recommended. So, in summary, for the fourth update, the general interpretation that IDH wild type tumors carried a worse prognosis is not always true, especially in children and young adults. As a result, it is important to designate at the present time the following as distinct entities for prognostic and potential therapeutic implications. The fifth update was published last year by Working Committee 1, and it proposed several updates on the classification of IDH mutant astrocytomas. This update was also discussed in the lecture by Dr. Ballister. The integrated diagnostic entities of IDH mutant diffuse astrocytomas include diffuse astrocytoma IDH mutant, WHO grade 2, anaplastic astrocytoma IDH mutant, WHO grade 3, and glioblastoma, IDH mutant, WHO grade 4. The current grading criteria were developed prior to the understanding of molecularly distinct entities, yet the WHO updates applies the same grading criteria for both IDH mutant and wild-type gliomas, despite the more aggressive clinical behavior of the latter. So this update addresses that dilemma. In particular, multiple retrospective studies have concluded that the histologic grading criteria may not stratify risk for patients with IDH mutant astrocytomas in WHO grade 2 and 3 categories. In an attempt to improve risk stratification, several studies have investigated potential morphologic, proliferative, or molecular markers that correlate with aggressive clinical behavior and could be incorporated into a more clinically relevant setting. So, among the potential morphologic, proliferative, or molecular markers, multiple studies have identified homozygous deletion of CDKN2A/B as an independent marker of poor prognosis, with shorter survival in patients with IDH mutant diffuse astrocytomas across all histologic grades. So, other genetic markers of interest did not show strong evidence for the ability to stratify risk or predict WHO grade 4 behavior. So, with this update, CDK and 2A/B homozygous deletion can be determined by the following test platforms. Unfortunately, it is important to take note that the immunohistochemistry for P16 does not correlate well with deletion. Since we now understand that IDH wild-type and IDH mutant tumors represent distinct clinical and genetic entities, it is suggested that diffuse astrocytic gliomas that are IDH mutant would be separately graded based upon morphologic and genetic features that correspond to WHO grade 2, 3, or 4 clinical behavior. For astrocytoma, IDH mutant WHO grade 2, it is a diffuse infiltrative astrocytic glioma with an IDH1 or IDH2 mutation, as well as differentiated and lacks histologic features of anaplasia. Mitotic activity is not detected or low. As opposed to astrocytoma, IDH mutant, WHO grade 3, it is defined as a diffuse infiltrative astrocytic glioma with the same IDH1 or IDH2 mutation that exhibits focal or dispersed anaplasia and displays significant mitotic activity. So, significant mitotic activity remains a criterion despite no validated published criteria exists for the cutoff. Most neuropathologists use a threshold of greater or equal to 2 mitosis within the entire specimen or 1 mitosis in a very small biopsy. For IDH mutant astrocytomas with microvascular proliferation or necrosis, it is presently classified as glioblastoma IDH mutant WHO grade 4, but it is now proposed that the term glioblastoma should be reserved for diffuse astrocytic gliomas that are IDH wild type and have features predictive of a highly aggressive grade 4 tumor. So as a result, IDH mutant astrocytomas with microvascular proliferation or necrosis or CDKN2A/B homozygous deletion or any combination of the features will correspond to astrocytoma IDH mutant WHO grade 4. So the sixth update was published on March of last year by Working Committee 3, and the update doesn't give an actual answer to a particular driving question, but instead it summarizes the consensus of the previous updates. So after releasing 3 years worth of publications, the Working Committee 3 was reconstituted and convened in Utrecht, the Netherlands, for a meeting designed to review new CNS tumor types in and revised old entities. A total of 26 neuropathologists attended, as well as 3 oncologists and 3 representatives from the WHO. The cIMPACT Utrecht meeting established the following principles in the hope that they will guide future efforts in CNS tumor classification and grading. So the current WHO recommendations use the parallel terms types and subtypes instead of previously using entities and variants. And the meeting participants encourage future CNS tumor classifications to use these terms to conform with terminology used across other organ systems. Classifications can group tumor types in different ways. So, potential models for classification of pediatric type glial or glioneuronal tumors and ependymomas were presented, and these were wonderfully illustrated in the lecture of Dr. Velasquez Vega. So, in terms of tumor nomenclature, some suggestions were made to modify the names of some tumor types, and methylome profiling has been shown to provide powerful information for the classification and diagnosis of selected CNS tumors, such as your medulloblastoma and ependymomas. And lastly, CNS tumor grades will revert to using Arabic numerals instead of Roman numerals. Although not exhaustive, the meeting participants endorsed the following specific types, subtypes, definition, and grading criteria and recommended these entities to be considered for the next WHO classification. So these are the newly recognized type, subtypes, or diagnostic criteria or family of tumors. These are existing types with suggested name modifications and retentions, while these are sub judice or entities that lack sufficient published evidence to make a decision. So these entities belong to those with NEC or not elsewhere classified designation. The latest update was accepted for publication on May of 2020, and it proposed a classification of ependymal tumors according to the location and molecular status. So, ependymal tumors make up a heterogeneous category of CNS gliomas with variable expression of morphologic, immunophenotypic, and ultrastructural features. The current WHO lists the following as specific subtypes. However, this scheme is found to be not ideal since there's poor association between tumor grade and outcome. So as such, this update seeks to improve the current classification. Methylation and gene expression profiling studies have provided evidence for at least 9 molecular groups of ependymoma across the three principal anatomic compartments. So the supratentorial, the posterior fossa, and the spinal cord compartments. These molecular groups have distinct alterations and clinical pathologic characteristics, and their identification has clinical utility. One molecular group at each anatomic site consists almost entirely of tumors with the morphologic features of subependymoma. Of the two remaining supratentorial molecular groups, one is dominated by ependymoma with C11 or F95 rela fusion gene, and the other contains tumors with a high frequency of YAP1 MAMLD1 fusions. So, posterior fossa ependymomas lack recurrent mutations, but methylation profiling divides them into two main groups, namely PFA and PFB, which are also distinguished by global levels of histone H3K27 trimethylation, which is high in PFB but low in PFA ependymomas. So, the importance of separating the subtypes is related to the fact that some PFA ependymomas show a significantly worse prognosis. So among your spinal cord ependymomas, there are the myxopapillary tumors that predominate in adult patients. The recommendations would show that ependymomas should be classified by anatomic site and by molecular subgroup. For subependymomas and myxopapillary ependymomas, the relationship between morphology and methylome group is imprecise, so they should still be identified by morphologic criteria. Morphologic subtypes such as your papillary clear cell tanacytic ependymomas should no longer be included in the classification of the disease. They are only recognized as distinctive patterns but actually have no specific clinical utility. So when molecular testing is unavailable, then ependymomas plus the tumor location is usually included with the suffix NOS or not otherwise specified. A range of diagnostic tests can be used to discover the molecular alterations that define the new types of ependymoma, such as your next generation sequencing and DNA methylation profiling. An integrated and tiered approach to reporting the diagnosis is recommended again for capturing information on molecular characteristics alongside histopathologic features. So, knowing all these updates, what would be the impact on the upcoming 5th edition of the WHO classification for tumors of the CNS? Preparation for the 5th edition are now in full swing and publication is again expected this year. While most of the cIMPACT Now recommendations summarized previously are likely to be incorporated in the new WHO classification, because of even more recent insights, there might be more modifications down the line. The guidelines suggested the use of Arabic instead of Roman numerals in histologic grading, discussed new and revised specific types, subtypes, and definitions of tumors, and further reinforced the applicability of the paradigm shift in tumor classification, and emphasized the use of not otherwise specified category. Traditionally, CNS WHO tumor grades have been in Roman numerals, with a grade assigned to each entity. So, histological grade is a means of predicting the biological behavior of a neoplasm. In the clinical setting, tumor grade is a key factor influencing the choice of treatment. Just a review, grade 1 refers to tumors with low proliferative potential, and the high possibility of cure after surgical resection alone. Grade 2 tumors are usually infiltrative in nature and often recur despite having low levels of proliferative activity, and patients typically survive for more than 5 years. Grade 3 tumors show clear histologic evidence of malignancy, including nuclear atypia and sometimes brisk mitotic activity, and patients have an average survival of 2 to 3 years. Lastly, grade 4 tumors are cytologically malignant, mitotically active, necrosis prone neoplasms that are often associated with rapid pre and post operative disease evolution and fatal outcome, and prognosis would depend heavily on the availability of treatment regimens. Many tumors in other organ systems are graded within tumor types, and as such, grades are often given in Arabic numerals. Using Arabic numerals as well will result to a more uniform approach to tumor classification and grading. The danger of using Roman numerals in a within tumor grading system is that 2 and 3 or 3 and 4 can be mistaken for one another, and an uncaught typographical error could have clinical consequences. So the switch will actually decrease the possibility of errors. In the subsequent slides, I will touch on specific CNS tumor types, subtypes, and definitions that may be altered in the next edition. So the terms used to classify diffuse infiltrative gliomas are deeply rooted in history and based on presumed tumor lineage and levels of differentiation. For diffuse astrocytic gliomas, we now understand that IDH wild type and IDH mutant tumors represent distinct entities, and therefore it is suggested that the diffuse astrocytic gliomas that are IDH mutant would be graded based upon morphologic and genetic features that correspond to WHO grade 2, 3, 4 clinical behavior. So, the approach to the diagnosis of glial tumors will start with the classification of IDH wild type versus IDH mutant tumors. So, if you were to choose which IHC stain to use on a glioma, the first thing that should come into mind is IDH1. The suggested definitions and grading of IDH mutant astrocytomas were already previously discussed and shown here. So glioblastoma, IDH mutant, will be removed, and the term glioblastoma will be reserved for IDH wild-type diffuse astrocytic glioma with microvascular proliferation, necrosis, or any one of the molecular alterations. Another new IDH wild-type diffuse glioma is the diffuse glioma with H3G34 mutation. And in addition, a separate category for pediatric type glial and glioneuronal tumors is also suggested. Among ependymomas, overlapping histopathologic features can be associated with markedly different clinical behaviors. So as a result, we will most likely see the incorporation of site in addition to the distinct genetic and epigenetic signatures into tumor nomenclature. Most likely, we will see at least 9 types of ependymomas as previously discussed. For entities that are lumped under other gliomas in the WHO, the location in choroid glioma of the third ventricle will be deleted since the tumor is not really exclusively seen in the third ventricle. As for astroblastoma with MN1 alteration, it is already considered as a specific type. So tumors with classic astroblastoma morphology in which MN1 alterations cannot be tested will be designated as astroblastoma, not otherwise specified. While a tumor that shows the classic histology of an astroblastoma but doesn't carry the mutation after testing will be designated as astroblastoma, not elsewhere classified. So lastly, CNS tumors with B-core internal tandem duplication is a malignant tumor that is considered by the group as a distinct tumor type and might be added into the classification of other gliomas. As for neuronal and mixed neuroglial tumors, recognition of several distinct tumor types may be included in the next edition. So, diffuse leptomeningeal glioneuronal tumor has been promoted from a provisional entity to a distinct tumor type, with two subtypes, with the second type showing a shorter patient survival time compared to the first type. Myxoid glioneuronal tumor could be placed under this category and suggested to have a clinical course similar to a grade 1 entity, with DNA methylation signature closely related to your DNTs, or dysembryoplastic neuroepithelial tumor. Another new distinct tumor type is polymorphous low-grade neuroepithelial tumor of the young, also known as plenty, which is a neoplasm occurring predominantly in children and young adults and have a strong association with epilepsy. Another addition is multinodular and vacuolating neuronal tumor. So originally, it's included in the 2016 edition as a histopathologic pattern in the commentary on ganglion cell tumors and is now considered as a distinct tumor. So as for the controversial pineal parenchymal tumor of intermediate differentiation, there is still no genotype or information that signifies it as a specific type or subtype. So classification remains based on morphology. Medulloblastoma will most likely have the same molecular and histologic classification, and this approach afforded great flexibility as well as provided key diagnostic features. A tumor that might be listed with other CNS embryonal tumors is the CNS neuroblastoma, FOXR2 activated. This is the most frequent alteration in tumors histologically classified as CNS neuroblastomas. An NEC designation is suggested for those with other genetic events. So lastly, the committee discussed CNS tumors that have CIC alterations and didn't feel like there's sufficient evidence to distinguish it from histologically and genetically similar entities found elsewhere in the body. So it is therefore recommended that the classification of CIC altered sarcomatous neoplasms conform to the classification of tumors of the soft tissue and bone instead. So, given the rapid pace of advancement in the biological sciences, it was not surprising that the WHO 2016 edition was already out of date at the time of publication, and this might still be the case for the upcoming 5th edition. The ongoing discovery of promising biomarkers and new drug targets will further fuel the need to accelerate the revision process. The integrated diagnostic workflow used in CNS tumor diagnostics depicted here starts with microscopy for standard histologic evaluation and adds on novel molecular platforms such as next generation sequencing and genome wide DNA methylation profiling. So the next edition will most likely reinforce this paradigm shift in tumor classification, and in time, all of the WHO Blue Books will incorporate the combination of histomorphologic and genetic data in the approach to diagnosis. So what does this mean for the Philippines? In places that do not have access to such technologies early on, the generous use of the NOS or not otherwise specified label and subsequent diagnostic referrals may provide utility during the transition period. So, retention of the NOS category is actually in consideration of countries that don't have access to extensive molecular testing, such as our own. So, be that as it may, introduction to new technologies will require extensive adaptation of current clinical practice, and for some entities, the NOS criteria may no longer be acceptable, especially when treatment guidelines and clinical trials will require a targeted approach. Hopefully, with the eventual advances of molecular testing in our country, there will be less frequent use of the term NOS in the future. And with that, I end my lecture. So So feel free to leave any question or comment. Thank you very much for your kind attention and stay safe, everyone.